at the door. But a crisis at its core is about unpredictability and stress. It's when the situation overwhelms the supports that we have in place.
Yeah, sorry, we were having an audio issue. Okay, now keep going.
Are we okay now?
Yeah.
Wonderful. So families tell me, in these moments of crisis, a few things. That they often freeze. They describe feeling like the whole world goes blank and they don't know the next step. It's not necessarily because the caregivers are unprepared. It's because our brains are literally wired to shut down under this type of threat. A crisis plan does not eliminate the stress.
New message. Thursday, 10:37 a.m.
So a crisis plan.
End of messages.
Alrighty. So a crisis plan does not eliminate the stress, but it does reduce the uncertainty. So imagine a roadmap that says, when this sign shows up, here's what to do. When things get harder, here's the next step. That roadmap means that you don't have to rely on your memory when you're overwhelmed and trying to navigate a crisis. These plans also give clarity to everyone that's involved. Parents aren't the only ones who need direction during a crisis. Siblings, grandparents, other service providers, babysitters, respite workers, they all will feel a lot less anxiety when they know what role they need to play. Even first responders can use a crisis plan to enter a situation calmer and more effectively. So today, when we're talking about crisis plans, we're talking about, the binders are gathering dust in your closets. We're talking about the living, breathing guides that really are geared towards being digestible and usable. I want to talk about some common barriers. So let's pause here a bit and talk about why so many crisis plans fail. I've sat with families who've been handed 18 to 20-page crisis plans, written with a lot of jargon, a lot of clinical language. They're full of good intention. But when an individual is in crisis in the living room at 10 o'clock at night, I know very few parents who are just going to pull out a binder and turn to page 9 or 10. Another issue is that oftentimes the crisis plans are written once and they're never practiced. Imagine if we only went through a fire drill once in our life. Would we know what to do when the alarm goes off? The same applies here. A crisis plan is only as strong as the practice behind it. Families also tell me that oftentimes, plans just jump to, the most severe crisis, straight to stage 3, the worst case scenario, without helping them think about mild or moderate levels of crises. This is important because this is when de-escalation and prevention are a lot easier. Finally, crisis plans don't reflect the actual rhythm of the family. When they don't take into enough consideration, the family's routines, bedtime routines, who's usually home at certain times, whether, siblings might need a safe space. When crisis plans don't reflect the rhythm of the family, they often will gather dust. So the crisis framework, crisis isn't just one moment. It unfolds in stages. And we use this framework on the screen to help families notice and respond earlier. So we start with baseline. It is our steady state. It may not always look calm, but it's what typical looks like. And it's really critical for us to understand what our loved one's baseline is so that we can use it as a reference point, so that we can gauge other mild, moderate, or severe crises. With mild crises, it's when early signs appear, and they might be, very small or subtle, subtle shifts, and someone might, begin a lot. Their tone might be, might change. They might speak faster, slower. But it's when the early signs of crisis start to appear. With moderate crisis, we're escalated. Distress is obvious, and the body is dysregulated. Now, moving to severe crisis, this is when, this is acute crisis, when their safety is at risk. So this framework reminds us that crisis is a process. It's a process. If we act early, we can help prevent escalation to more intensive crises. Next slide, please. So many of us, when someone we care for is upset, we jump right into problem solving. We might start explaining, giving advice, or trying to talk them through it. And usually it doesn't go very well. That's because there's an order that actually works better. And that's what this slide shows. It's the 3 R's. The first step is regulate. When emotions are running high, when we're in crisis, the body has to settle first. This might mean lowering noise, creating space, using a calming tool, or just showing a steady, calm presence. Once there's some settling, once we've engaged in some regulation interventions, we can move to relate. This is about connection. We may use a calm voice, calm tone, use very short words, or even just sit nearby. It's a way of saying, you're not alone, I'm here. Only after that can we reason. That's when we can problem solve, talk things through, or reflect on the crises. This is an important part. The order matters. If we skip ahead and try to reason too early, it can often make things worse. So what happens if we start in the wrong place? So again, a lot of us want to start with reason. We may explain, we remind, we try to teach skills in the moment. Remember what we practiced. Just use your words. Take a deep breath. But in that moment, the thinking brain is offline. Your loved one literally can't process, too many words. You can't reason. Explanations feel like pressure at this stage, and it often can escalate the crisis. So others of us may want to jump right into relate. We move in close. We say, it's okay, I'm here. Or we try to comfort right away. That can sometimes work, but if the body is still in fight or flight mode, even our kindness can feel overwhelming. Your loved one may push us away, yell louder, shut down further. And this is not because they don't need connection. Rather, it's because they're not ready for it yet. They need to first regulate. That's why we begin with regulate always, no matter the stage of crisis. We start by calming the body and the environment, lowering our tones, removing unnecessary noise, giving space, helping with deep breathing, for instance. The body begins to settle, the survival brain quiets. And now relational connection can actually land. So again, the sequence is really important. Next slide, please. Alrighty. So this chart puts a lot of this together. You know, the stages, goals, and how the 3 Rs for interventions fit. Again, I've said this before, and I'll say it probably a few more times. The most important point is you always start with regulate first, no matter the stage. So at baseline, this first row, this is where we really need to find or understand as a reference point what the baseline looks like for our loved ones. We need to know what the steady looks like. That doesn't mean that we need to necessarily intervene, but the important point is we need to know what the baseline is. With at the mild stage of crisis, stage 1, the goal is to prevent escalation. That's the goal. And again, you might start with regulate, lower stimulation, have a steady presence. You may then relate, then regulate, and then reason. You can reason only if calm enough to take in short direction, for example. At moderate stage of crisis, the goal is to contain escalation. Again, we're going to start with regulation, breathing, space, having a calm tone of voice, for example. We may add relate once you see that the person begins to settle down. Reason waits until the person is calm, because before we are calm, before we are regulated, the survival system is driving our behavior. And the thinking system, which is, lives right behind our forehead, prefrontal cortex, it isn't fully available to process language, logic, or choices. So at the severe stage of crisis, the goal now is safety. We need to, again, start with regulate to reduce danger. We're not going to try to relate or reason with somebody until safety is restored. So reason, again, we need to wait until calm. And Juliana will be discussing this a little bit more in terms of, the recovery, after the crisis. But a short line to remember is that if your loved one isn't calm, they're not available to reason. So here is a crisis plan in action. Simple, color-coded, and it's designed for real-world use. Something that you can even put on your refrigerator. It's something that can be given to teachers. It can be shared with respite providers or other service providers. And I want to walk through an example as if we're filling out this crisis plan for John Smith. So at the mild stage of crisis, John's early signs are pacing and humming. His triggers might include loud noises, transitions between activities, especially after school. So in the what to do, well, we'd write things like under regulation, regulate first with noise canceling headphones, offer movement breaks, lower stimulation. Then relate, relate with calm words like, I see you need a break. Once he's calm enough, or if he's calm enough at this stage, we might then reason a little. Let's step outside together. Let's take a deep breath. Let's practice deep breathing. On the right column, you'll see who to call, contact list. We included John's mother, Rhonda. And it's really important to actually include the phone number here. At a moderate stage of crisis for John, John is now yelling. He's refusing to move. Triggers at this stage might include being told no, or when a lot of demands keep on stacking up. What do we do? In the center column, again, we need to start with regulate. Give him space, lower our voice, remove extra people from the room. Once his yelling drops, we can then relate. You know, this is hard, John. I'm here. Reason still waits until they're in recovery. This last stage, the severe stage, John is throwing objects. He's beginning to engage in physically aggressive behaviors, including, punching, hitting, and biting. Safety at this stage is at risk. So what would we do? Again, we're going to regulate. We may want to move everybody out of harm's way. We want to stay steady ourselves. Once safe, we can relate, but this is in reason, but this is often not going to happen when someone's still in a severe stage of crisis. So with this practice example, you can see how the same framework fits into a simple fillable plan. On the far right side, you'll see some additional information that I would highly recommend you consider including in any one-page crisis plan. How old are they? Person's date of birth, any medical or psychiatric diagnoses, including, as an example, John has mild intellectual disability, autism spectrum disorder, and type 1 diabetes. I would recommend that you will include preferred hospital and any additional information that might be really helpful for someone responding to crisis. For example, if John's taking any medications. Again, on the right-hand side, you're going to want to include all the contact information that you'll want to utilize during each stage of crisis. The last thing I want to say for this slide is who to call when someone's at a severe level of crisis. Oftentimes, we need to call 911 or law enforcement. And I recognize that a lot of parents are sometimes afraid of that for a lot of different reasons. And one thing that I always like to recommend, if we do need to call 911 or law enforcement, inform the operator that John has an intellectual and developmental disability. Inform them that that John is having a mental health emergency. I would highly recommend including that. Alrighty. I'm going to pass the baton on to my program director, Juliana Hartsog, who will continue.
All right, thank you, Wajdi. As Wajdi shared, my name is Juliana Hartsog. I am the program director for California Start San Diego. Now that we've just reviewed putting a crisis plan into action, we would like to discuss what comes next. After a crisis, families often ask us, what do I do now? Or how do we come back from the aftermath of a crisis? And this is where recovery comes in. Similarly to the crisis framework Wajdi reviewed, recovery starts with regulation. After a crisis, everyone may feel drained, frustrated, or even still anxious. So it is necessary to reset. Ensure that all basic needs are met, that everyone has had time to rest, process, and decompress, while also ensuring basic needs like food, water, everything is renourished. It is also important to avoid blame. Remember, crisis is not anyone's fault, and it's a signal for support. Next slide, please. Now, once emotions have cooled and everyone has had the opportunity to regulate, it can be beneficial to hold a conversation with your loved one about what triggered the crisis and what strategies helped or didn't work. Now here, I do want to highlight that timing is so important. It is extremely ill-advised to discuss the crisis in the moment or immediately after, as it can be re-triggering and reactivate crisis presentations. But these conversations are not about punishment. They are a learning opportunity. It is an opportunity to walk with your loved one in identifying what triggered the crisis and what helped them come back to baseline. It can also be beneficial to discuss what didn't help. Then you know you can throw it right out of the crisis plan. This is also an opportunity to model, share your feelings in a calm and respectful way. By modeling how to communicate your emotions effectively, we can provide our loved ones with language they can use, hopefully before crisis occurs in the future. Now I'd like to discuss a bit about caregiver recovery. As we know, after crisis, this can leave caregivers feeling drained, anxious, and really just overwhelmed. One possible framework we can use to reset is called PERMA. PERMA is a positive psychology model that was developed by a psychologist by the name of Martin Seligman. It's a relatively new model. He introduced it in 2011. And essentially, PERMA is a framework for how to promote overall well being. PERMA is an acronym. Starting with P, we have positive emotions. In positive emotions, we're reflecting on what brings us joy, what brings us gratitude. In these small moments, we can find relief. Next, we have engagement. Engagement in activities that not only you enjoy, but that ground you. When we're talking about engagement activities, we're talking about activities that we are so enthralled in that we lose track of time, otherwise known as flow. When we find flow, it helps us rebalance ourselves. Next, we have relationships. Now, this isn't referring to just people we know or acquaintances. This is referring to meaningful connection and meaningful relationships. Next, we have meaning. Reflecting on what brings you purpose and a sense of belonging. And lastly, we have accomplishments. This is not only about completing a task or achieving a goal. This is about reflecting on accomplishments and acknowledging the achievement. It's about reflecting back and saying, I did it and I did it well. Now, the beautiful thing about PERMA is that these steps do not have to be huge undertakings. Each component of PERMA can be reached in small, sustainable actions. For example, positive emotions. This can be something as small as at the end of the day, writing down one thing you're grateful for. Prioritizing these elements promotes emotional healing, prevents caregiver burnout, and it builds resiliency. This same framework can be applied to promote well-being for all members of a family. However, there are some specific steps that can be taken to support siblings in recovery. First, we have giving siblings space to share their feelings. Siblings need to know their voice and experience matter. Encourage open conversations and normalize that it's okay to have mixed feelings. It's okay to feel fear, feel frustration, worry, or even jealousy while still loving and caring and want to support their sibling. Spending one on one time with siblings strengthens your bond and also helps build security. And by building security in measurable steps and consistent security, it can help promote that feeling of safety and reassurance, even when the environment feels very insecure. When possible, offer one on one time and remind them that it's okay to have their own needs and boundaries. When developing a crisis plan, it's okay to sit down with a sibling and say, what do you want your role to be? Do you want it to be that you just go to your room or go to a safe space in the home? Next slide, please. As we close, please remember, crisis does not define you, your loved one, or your family. It's a signal that support is needed. And with patience, compassion, and the right tools, families can recover and grow stronger. Also, please remember you are not alone in this journey. Support is available, and small steps forward make the biggest difference. As we close today, I'd like to highlight some key takeaways. First, as Wajdi reviewed, crisis builds in stages. Act early. The sooner that we are able to intervene and support a crisis, the better the outcomes we have. Always stick with regulation, whether that's in crisis intervention or recovery. Then move to relate and then reason. Next, related to the first takeaway, crisis comes in stages, and our interventions need to accommodate and reflect what that stage is. Stage 1, mild crisis. Stage 2, moderate. And stage 3, severe. Next, keep family plans realistic and consistent and sustainable. Keep them family-centered in practice. Crisis prevention and intervention is a skill. And just like any skill set, the more we practice it, the more effective we will be. Utilize PERMA. PERMA is a structured framework, and it's so beneficial to follow step by step for healing, recharge, preventing burnout, and just promoting overall resiliency and well-being. And lastly, recovery lies in authentic connection. Create space for your loved one, for yourself, for all members of your family to connect, hold open conversation, and share strength. Next, we'd like to open up the opportunity to ask some questions, and hopefully we have some answers.
We had one in the chat.
Oh, beautiful.
Why don't you go ahead?
Okay.
Read
It
those, and then
says-
when we're done, we're gonna also, so I want to thank both of you for that presentation. We're going to take some questions from the audience. Once that's done, I thought it would be helpful for our guests to also learn exactly what the START program is. I think information about how you access START here in San Diego, as well as what the components of that program are. So Wajdi has agreed to share that with us, but first we'll go to the questions.
Great, I have one. It says, what do you do if you are trying to help a child regulate with breathing or creating a calm space or introducing favorite sensory tools, and the student just screams that they don't want to?
It's a great question. Thank you for that question. It's really important to have more than one coping strategy, more than one strategy or intervention. I might really like a particular grounding exercise. I personally don't like deep breathing. I think that's something that all of my colleagues know. It's not something that works for me, at least not very well. But I do know that, other types of grounding exercises do work for me. With that being said, there are many times where I might be in a particular, situation, and either, engaging in that coping strategy isn't feasible, or it's not something that I'm interested in doing at that moment for whatever reason. So with that, I would really say I would make a recommendation to put some more tools in your toolbox, increase different types of interventions, because there are, there may be factors or situations where your current tools aren't helpful.
Just to add to Wajdi's point, yes, absolutely, increasing a toolbox. However, it is also beneficial to increase the toolbox with passive interventions. So we have active interventions like utilizing sensory tools and fidgets. But as we know, going back to regulate, that doesn't necessarily mean that somebody has the capacity to use those tools. So that's where we introduce passive interventions. Are there things we can change in the environment that can help the student or child regulate, whether that's dimming the lights, seeing what noises we can reduce, in lieu of having that student or child actively do an intervention.
Can you so with that in mind, do you recommend two parts to this. One, do you recommend sort of doing an FBA to figure out what sort of is going on around the person that led to the crisis? Because that's where you come in with your passive interventions, in my view, is if the child is in an X setting and it's because there's 20 kids and then they always have a behavior. So I don't know if an FBA is part of that kind of identifying, because we can kind of guess what the interventions are that are going to work for the child, but I also think there needs to be perhaps a systematic review of what works for this. To your point, Wajdi, reading doesn't work for everybody. So what do you recommend happens to in anticipation of a crisis so that you know what those passive and active interventions can be? So how do you get to that place to know what to do, what to use?
Sure. I would also start by saying this is why it's so critical to have a good understanding of someone's baseline. And that baseline can absolutely shift and change. So once we have an understanding of someone's baseline, we're going to be in a much better position to also, engage in some clinical conceptualization, take into consideration, what biopsychosocial factors may be at play. Recognize, at San Diego Start, we facilitate certain assessments. So, for example, we might do a sensory assessment to try to gauge, someone's sensory profile or sensory needs. Once we have that information, we're in a much better position to, select the regulation, the relate, and the reasoning interventions that are in line with the person's, biopsychosocial vulnerabilities, but also their strengths and interests. Project.
There's a follow-up question online. So there's two questions. I'm going to do the follow-up first, and then I will get to your question, Andy, as well. But there's a follow-up to when they're referring to the student who, may scream they don't want to. With the student I have in mind, he has run out of the classroom and running around campus while we try to keep eyes on him. I guess that's just kind of, maybe not really a question, but kind of a.
I mean, one thing that I think would be important. It's going to be important for us to try to gauge why that person might be running away. Maybe they're bored. Maybe they're in a lot of dental pain, and because of their, expressive communication fluency, vulnerabilities, they're not able to communicate that they're in pain, that they're in distress. Is that why they're running away? Are they running away? Is this maybe a potential side effect from certain medications, for example? This is again the importance of recognizing someone's baseline, and also having a good understanding of someone's, vulnerabilities and strengths, because we can start to ask questions like, is this person, leaving and running away? Are we able to gauge what's the foundation of that, where it's rooted from?
Great, thank you. We have another question. Isn't there a regional center funded crisis team thing you could use before it gets to calling 911?
Absolutely. Absolutely.
It's the thing you could use.
Probably close the.
Oh, actually,
There's
on the
more.
next slide,
There's resources. Yeah,
Oh, no, on the next slide, we do have resources if we want to leave those up in the area.
absolutely.
It's good segue.
Yes, indeed. So San Diego START is a part of a national organization called the National Center for START Services. We exist all over the country. In California, San Diego START was one of the first START programs in the state. We were one of the pilot programs. I believe it started in 2019. And this program is a crisis intervention and prevention program. So what does that mean? So in terms of the intervention component, we have a 24-hour, 7-day-a-week crisis support line that caregivers can call when they're experiencing a crisis and need support. We will answer at 2 o'clock in the morning, at 3 o'clock in the morning, on New Year's Eve, whenever it is. And if needed, we will go and have in person a crisis response. Again, we're not hands-on. Our support is really aimed at supporting the caregivers in handling the crisis. We can certainly, serve as like maybe a liaison or try to connect somebody with MCRT or PERT, for example. But we are not first responders. And that's a really important piece to our program. We are not first responders, but we do learn from crises that we do respond on. And we come back with our clinical team. And another part of our program is a crisis prevention piece. And every person who's enrolled at San Diego START is assigned a START coordinator who will work with the person's system of care, system of support. I like to think of our START coordinators as bridges between islands. Oftentimes, folks might have a bunch of different services, a lot of different service providers involved in their life. But oftentimes, these service providers are living in isolated bubbles, different islands, and they're not connected. So one aspect of our work is insisting or ensuring that there is connection between various system members so that we can all have a better understanding of why crises are occurring and how to effectively approach these crises. We have a coaching component as well at San Diego START. Our team is comprised of, we have two medical directors. They are both psychiatrists. They do not prescribe, they're more consulting psychiatrists. We also are one of the few START programs that offer families and caregivers consultation time with our medical directors. The medical director at our program, Dr. Jude, is a board certified child, adolescent, and adult psychiatrist. He also has a PhD in genetics. Very, very smart guy and very approachable. So that's a bit about our program. It is not a program that is intended to keep folks enrolled forever. We are temporary. Our goal is to get out of the system once we stabilize the system and really help support the system in terms of understanding crisis prevention and intervention. All referrals come through the regional center. So that's an important aspect. So if you know anybody, 6 and up is our age group, with some flexibility on the lower age. If someone's like 5.5, about to turn, we can talk. But we serve children, adolescents, adults, elderly adults, the whole spectrum, really. What am I missing?
That's really all of it. But I would just like to highlight a big part of our prevention piece that our coordinators do complete is what she likes to call them bridges. I call them detectives. One of their primary goals is to find out why is crisis occurring through that biopsychosocial concept. So are there gaps in services, gaps in interventions, gaps in medical care, and how can we fill those gaps?
So we have two other questions. They said they need this, but they're in Orange County. Do you know of anything that's similar like this in Orange County?
Orange County. So eventually, every single regional center across California will have a START program. Orange County does not have one yet, I don't think.
I don't believe so.
There are all of the ones in Los Angeles have START programs. But with that being said, I know that they are actively in the process of developing these teams in Orange County, as well as for the Inland Empire Regional Center, Kern County. But I will say, stay tuned. If it hasn't already been contracted out, it will probably happen very soon. They're actively working on implementing START programs at every regional center in the state.
Awesome. And then do you have any resources where parents can get CPI training?
So,
Yes, thank you, Shirley.
So CPI is crisis prevention intervention. Really, it goes over the physical aspects of crisis, how to evade maneuvers and how to physically intervene. That is a common resource that is requested by families. Unfortunately, we do not have knowledge of any resources that offer CPI training directly to families, but that is something we're continuing to look for.
All right, I just asked if there was any other questions. I don't know, audience, did you have any questions?
Thinking just on a very, not extreme level, but your thoughts about some of the de-escalating behaviors or like my thought was, how do you gauge what's reinforcing to the behavior? Like, oh, hey, if you're upset and acting this way, then we do something that feels good to you. How do you gauge that that's not tied together, that, oh, this is how I get this thing that makes me feel happy or comfortable?
Absolutely. It's a really good question. I think it's important for us to recognize that when we're in crisis, it's not purposeful. You know, there's neurochemistry, neurobiology that, behind it. When we're in crisis, our executive functioning is not, working where it needs to be. And that's all of us, not only individuals navigating, IDD. When I'm not at my best, okay, when I might be really stressed out or myself, I'm in crisis, um, my impulse control probably is not going to be where it needs to be. My capacity to plan and organize is probably not going to be where it needs to be. My capacity to engage in some emotional regulation, unfortunately, is probably not where it needs to be. And that's not because I'm purposely trying to be maybe difficult. It's important for us to consider, that behind it, what's behind the crisis. Remember, crisis is any time our resources are not sufficient for us to navigate a challenge. And unfortunately, with many individuals that we work with at START, folks navigating neurodivergence, many folks have challenges or vulnerabilities with many of their executive functioning. So when they're in crisis, this can become even more of a challenge. So with that being said, I get that question a lot. Are they doing this on purpose? And then I'm going to give them a preferred activity to regulate. Am I reinforcing it? And I would say that, again, it's not purposeful, and our need, the necessity for us to be regulated, is a prerequisite before we can even start to relate and reason. That's a really good question, and a question that comes up a lot.
So of the resources that we have on our screen right now, which are the best 2 to 3 to start with? My son was diagnosed recently at 16. The diagnosis missed because of other neurological disabilities, ADHD, anxiety, depression, genetic disabilities, and motor delays.
I have a bias.
They're asking, so let go for it.
But I would definitely consider San Diego START. Most of the folks that we work with, all the folks that we work with, every single person who's been referred to START, they come because they're complex cases. Every single one. They'll have an intellectual and developmental disability and a co-occurring mental health vulnerability. Many folks will also have, medical conditions or genetic conditions that, might complicate things a little bit more. And these have, very real consequences, when we think about things like diagnostic overshadowing or misdiagnosing. So San Diego START really is a helpful program for someone who's navigating, a lot of co-occurring biomedical, psychiatric, and developmental conditions. I would also the Autism Ask line is really helpful. And I'm not just saying that because I'm at Autism Society. I almost didn't say it because of that, but I use it myself. I'm a clinical director for a San Diego START program, and it's something that I use all the time. I share that resource with as many people as I can. And they get back to you and they give you a lot of really great resources, and it's personalized and really helpful. Those are probably my favorite ones.
I would also highly recommend support groups, whether that's sibling support groups or caregiver support groups. Yes, they're incredibly beneficial in building community, but side note, they're also great for networking. Through other parents and caregivers, you can learn what resources are available that they have also utilized.
On that note,
there are specific that I read criteria for eligibility for START. Everybody can't just sign up for it for regional centers. So if you don't mind describing what are appropriate individuals for START services, what you look at to determine if this is somebody that you can or cannot serve.
So everybody has to have it needs to be regional center eligible diagnosis. So that might include autism spectrum disorder and intellectual disability. So apart from the regional center eligibility diagnosis, the individual needs to also be navigating a mental health vulnerability. This doesn't necessarily mean a diagnosis. We recognize that sometimes it's hard to get a diagnosis. So it can be, vulnerabilities, like maybe even symptoms of depression, for example. We need to have system involvement. Like I mentioned earlier, we're a little bit different than any other program that I've worked at in the sense that our focus of our support is to support caregivers and members of a system of care, the system of support. So that is a very important prerequisite, is that the family is willing and able to engage and collaborate and participate with us. Because at the end of the day, even though that we are going to temporarily come in as a member of someone's system of care, we're temporary. And the goal is deactivation. That's the goal. So we really need to ensure that there is a lot of collaboration with the system of care. Of course, crises, someone who's, experiencing a lot of crises, and their system of care, benefit from additional support and understanding the crisis, and then through that, intervening and preventing them.
Mhm. I would like to say as well, a system or family does not need to actively be in crisis to access START services. There can be the risk that crises can occur. So let's say a 6-year-old is referred and we're starting to see some concerning presentations. There can be referral to START services. Just like when intervening in crisis, the earlier we get in, the better the outcome. The same with START services.
Do you serve individuals that aren't living in the family home, or like, for example, individuals who are in group homes or those types of settings? Do you also provide services for them?
Absolutely.
Okay.
We don't,
Yes.
oh, go ahead. We have a question here.
Yes, for autism ADHD combination, is there one that might have more resources than others of that list, or just
Pardon?
for the combination of autism and ADHD?
Oh, so resources specifically for ADHD and autism.
Our ask lines.
The ask line.
It's a pretty common occurring, so like in our support groups, we have a lot of students.
Yeah, the last slide, we're gonna have some of our contact information. So you can take one of these since you're here, but we also have, some. A lot of copies of whatever is needed.
Wait, one more question.
Do you need a direct referral from the regional center, or can we contact you directly?
You need to reach out to the regional center. So the referrals come directly from the regional center service coordinator. But if we could certainly facilitate that conversation if needed. But I think it's going to be important to make sure that there is a service coordinator. So one way to get to try to get the referral is to reach out to the service coordinator and ask about the program, or you guys can reach out to Juliana, our program director, and she can maybe help facilitate that conversation with the regional center service coordinator.
It's the
Absolutely.
regional center funded service.
It is.
Yes.
Just so people know, it's not insurance, medical insurance, it's a regional center funded program. Service.
Wonderful. We don't see any other questions online.
Alrighty. Well, since there's so many of you guys online, on this slide, please feel free to reach out to Juliana and I, and we can send you a copy of this blank practice plan. And so forth.
Also, please feel free to reach out if you have any questions about resources or START services. We're more than happy to help. And please, if you can, take the time to complete our survey. Let us know how we did. If there's any areas for improvement, we're happy to hear.
Thank you.
So thanks everyone for joining, and this concludes today's presentation. We'll see you in a month. And next month, we will be talking about when living at home is no longer an option. We will have an expert on residential and community-based living options for our loved ones. Thank you.